Hello, everyone. Good morning, good afternoon, good evening, depending on whichever part of the globe you are in. Hearty welcome to today's epic lecture in our Learn from the Legends State of the Art International webinar series in neonatology. Thank you so much for joining us today. Now we will have an interesting discussion on a very common topic that most of us are perplexed very often, neonatal sepsis. We all know blood cultures are the gold standard of diagnosis, but when it is negative and baby looks septic and sick, what do we do? To help us navigate through this conundrum, we have none other than the legendary Professor William Benitz. In fact, personally, I am an admirer of this doyen of neonatology for the last 20 years, ever since the day I was scanning the literature to prepare a talk on the management of patent ductus arteriosus. And I happened to read his work and the guidelines he had prepared for the American Academy of Pediatrics. Today, ladies and gentlemen, we have this legend in person with us. Hearty welcome, Professor William Benitz. Thank you so much, sir, for joining us. To moderate today's session, we have two senior consultant neonatologists from India, Dr. Arjit Mohapatra from Odisha, India, and Dr. Ravindra Verma from Thrissur, Kerala, India. I would now request the moderators to kindly take over and request one of you to kindly inaugurate and introduce the speaker before we begin our lecture. Thank you.
Good evening, good morning, good afternoon, everyone. Thank you for joining. We have a true legend with us today to navigate us through a very difficult but yet commonly encountered topic, clinical scenario in neonatal practice, which we have all faced. None other than Professor William E. Benitz, who is a Professor Emeritus at Stanford University of Medicine in United States of America. He's a former chair of the American Board of Pediatrics, Sub-Board of Neonatal-Perinatal Medicine, and former Liaison member of AP Committee on Fetus and Liver. Dr. Benitz is the Philip Sunshine Endowed Professor in Neonatology Emeritus at Stanford University School of Medicine. He was born and raised in rural Alaska, and he received his undergraduate education from the University of Alaska at Fairbanks before completing medical school, residency, and fellowship training at Stanford, where he joined as the faculty in 1985. He served as the Senior Associate Chief of Neonatology for clinical programs for many years and as the Chief of Division of Neonatal and Developmental Medicine from 2007 to 2017. Dr. Benitz served as a member and chair of the American Board of Pediatrics, Sub-Board of Neonatal-Perinatal Medicine. He was a member of the AP Committee on Drugs and served as the AP Committee on Fetus and Newborn, contributing to numerous policy statements and practice guidelines. His recent work has centered on evidence assessment, decision analysis, and practice evaluation, including analysis related to early diagnosis and management of prevention of neonatal infections, and evaluation of evidence for treatments intended to induce closure of persistently patent doctoral attaches in preterm infants. The unifying thread within these studies is the rigorous application of quantitative methods to assessment of evidence of practice, informed by an intimate familiarity with the practice of neonatal medicine. That is about Professor William Benitz, the legend with us today for the lecture. Thank you.
Thank you, Arjit, for introducing our legendary speaker. Hi, everyone. As you all know, we are extremely delighted to have him for this edition of this Learn from the Legends. Babies with suspected sepsis, as you all know, is a problem for neonatologists. Many newer diagnostic modalities are coming up, but most of them may not be available in a resource limited setting. So to talk all about this, we have Dr. Benitz, and wishing you all an excellent teaching experience. I invite Dr. Benitz for this talk. Dr. Benitz, please. Sir.
Well, thank you for that very kind introduction. And thank you to Dr. Manoj for inviting me to participate in this series. To be invited to a Learn from the Legends series as a speaker, placing me in the pantheon of the many prior speakers in this series who I do consider to be legends is really an incredible honor. And I'm very pleased to be here, both to be among that group and to share a few thoughts with you about a topic that, as you just heard, we all grapple with every day in our regular practices. You will notice that the title of this talk is not culture negative sepsis, and I will try to address the reason for that in the course of this discussion. I'm afraid that the state of the science is such that I may provide fewer answers than questions, but if I can provoke a few questions and perhaps an alternative way of thinking about our approach to this problem, it will be helpful to you. So I do have one disclosure, which is that I'm an advisor to Melio Labs, a developer of molecular tools for diagnosis of bacteremia, with a particular focus on diagnosis of bacteremia in neonates, for which I have received stock options. But I do not believe that this advisory capacity to this commercial enterprise in any way conflicts with the topic of discussion today. I have no other financial or other conflicts of interest to disclose, and there won't be any discussion of off-label products in the course of this. So what's the problem? The challenge that we have is that collectively, and this is true worldwide, we as neonatologists and as the pediatricians who follow our lead have an absolutely disproportionate response to the risk of infection in newborn babies. And if we look across these various different reports from the last decade or so, all from high-income countries, I must point out, we see that the proportion of infants who are treated for greater than 7 days who actually have culture-positive proven sepsis, as shown in the dark red, is really quite small, consistently less than 25%, and sometimes as little as 4 or 5%. The ratio of babies who are treated for culture negative sepsis to the ones that actually have sepsis ranges from 4 to 1 to 15 or 16 to 1. So the vast majority of the babies that we're treating for sepsis actually don't have proof that they have a bacterial infection. The underlying logic behind this is that we all know that blood cultures have a low sensitivity for neonatal sepsis. And because of that, we know that we have to treat a lot of babies with culture negative sepsis. And because we have to treat a lot of babies with culture negative sepsis, we know that blood cultures have a low sensitivity for neonatal sepsis. So at this point, I would like to pose the question to the audience. Is it true that blood cultures have a low sensitivity for neonatal sepsis? Can we bring up the first question? Do we have a response there?
Yes, sir, here it is.
Okay, we can see from the audience response here that by a 5-to-3 proportion, the belief is that blood cultures have a low sensitivity for neonatal sepsis. So what I'd like to do in the next few minutes is to challenge that perception, because I think that the correct answer to this question is actually no, and I will try to show you some evidence for that. The first body of evidence related to this actually comes from the blood banking literature. Our colleagues in the transfusion service are very concerned about the possibility that platelets may be contaminated with bacteria. So they routinely culture the pack of platelets that they isolate from donated blood, which must be stored at room temperature. It's not possible to freeze them in the way that it can with red blood cells. And because they're at room temperature and they may have a duration of usability of 10 days to 2 weeks, there's plenty of opportunity if there's just a single bacteria in that bag of platelets for it to blossom into a full-blown culture. And if that's infused into a patient, it can be quite catastrophic. So the blood banking services are very concerned that when they sample their platelet units and culture for the presence of bacteria, that they have a high sensitivity. So here are two studies, one using the Bactec system and the other the Versatrac, both modern automated blood culture systems. And when they studied the minimum number of colony forming units per inoculum that were required to achieve a positive blood culture or positive culture of the platelet unit, they found that the minimum concentration that was required was on the order of 1 CFU per ml, the middle line going across the center of this graph. So this suggests that if there's a single organism present in the inoculum put in the blood culture bottle, that the culture will be reported as positive by the diagnostic system. If we look at organisms that are more relevant to neonatal sepsis, including the list shown here, there's another study which was done by Dr. Shalanka, who's now the chief of neonatology at University of Oregon in Portland. While he was in the military, he was allowed to use 3,840 culture bottles to inoculate them with organisms, Group B strep, E. coli, Staph epidermidis, and Candida albicans at various low concentrations. And then he did the analysis the correct way, where he established something that was called a positivity index. Now, when you're dealing with low quantities of inocula, where the density of bacteria in the inoculum is very low, not all of the ones, the 1 ml samples that you use will have an organism in it. So the question that Dr. Shalanka asked was, what is the ratio of the number of positive cultures that were observed to the number that would be expected based on a Poisson distribution? And he found that across the board for these organisms inoculated at low densities, the positivity index was essentially 100%. So again, if there was a single organism present in the inoculum placed in the culture bottle, there was essential certainty that the culture would turn positive. So at this point, let's ask the second question, which is related to the density of bacteremia in newborn infants. So the density of bacteremia is less than 10 CFU per ml in what proportion of neonates with confirmed bacteremia? In other words, what proportion of the babies who have bacteria in the blood have the bacteria present at that low density?
Here are the
So we
results.
have pretty much uniform distribution, except very few members of the audience believe that this is a very rare event with essentially none of the infected infants having the presence of bacteria at less than 10 colony forming units per ml. It turns out that that is the correct answer. It is very unusual, and essentially 0% of infants who are bacteremic have low density bacteremia. And that conclusion is based on this data. So here is data from one of the very few quantitative blood cultures samples where these investigators looked at quantitative cultures, which are actually rather difficult to do, in 71 babies who did have culture-proven bacteremia. And they found that 80% had bacteremia at greater than 100 CFU per ml, and 90% had bacteremia at greater than 10 CFU per ml. If only 10% of the population has bacteremia, then only 1% of the population will have bacteremia less than 10 per ml. So the closest answer to correct here is actually 0. But as you can see, the density of bacteremia in babies with culture-proven bacterial infection is actually quite high, typically greater than 100 and almost always greater than 10 colony forming units per ml. Well, if we go back to the analysis presented by Shalanka and look at what the Poisson distribution tells us about the relationship between the density of bacteremia and the probability of a positive culture, we see the curve shown in the red line, which is defined by the equation showing on the lower right. The Poisson distribution predicts essential certainty of having at least one organism in a 1 milliliter inoculum if the density of bacteremia is greater than 5 colony forming units per ml. And as I've just shown you, in neonates, typically it's greater than 10 CFU per ml. So as the density of bacteremia increases, the probability of achieving a positive culture also increases in this sigmoid fashion, such that 99% probability of achieving a positive culture with a 1 milliliter inoculum of blood with 5 colony forming units per milliliter. So if we take this one step further and we ask the question of what is the probability that paired blood cultures obtained at the same time will be discordant. That is, one of them will be positive and the other negative with low density or ultra low density bacteremia. We see the relationship shown here. The top curve shows the probability of discordance for a single pair of cultures with the probability of discordance reaching a maximum, or the probability of no discordance, that is, the results are the same, reaching a minimum of 50% at a density of bacteremia just below 1 colony forming unit per ml. If we do 2 pairs of cultures, the probability that neither will be discordant is at that concentration is only 25%. If we do 3, only 12.5%. If we do 4, only 6%. And if we do 22 pairs, and I'll show you in a moment why I picked that unusual number, we see the bottom line, which shows that the probability of discordance, of there being no discordance in a collection of 22 paired cultures from bacteremic babies at densities between about 3 and 0.01 milliliters is right down there on the 0 probability line. So at this point, let's pause for the third question. So if we do paired simultaneous blood cultures on a series of neonates in whom the prevalence of bacteremia is 10%, which is actually higher than in most of the case series that we see, as I showed on that earlier slide, what's the best estimate for the proportion of them that yield discordant results, one positive and one negative? For this question, we can assume that the series includes, let's say, 20 or more infants.
Here are the results.
Okay, it's a difficult question, and we see quite a spectrum of results. The correct answer to this question is actually A. Since babies have a relatively high density of bacteremia, and we're doing multiple pairs of cultures, we're going to be operating on one of the lower lines on the graph that's shown in the background. And in the range of low density bacteremia, the probability of discordance is very, very low. So the correct answer for this is actually the percentage that yield discordance results should be 0 because of the high density of bacteremia. Okay. We can go on. Given this information from the Poisson distribution, we can see that low density bacteremia is very likely to yield discordant blood results. The probability of seeing none is very, very low. And the absence of that discordance is actually a strong argument that low density bacteremia is very rare in neonates. So what do we know from empiric data? Well, here's a paper from Dr. Sarkar from now getting close to 20 years ago, but still using modern technologies, where they looked at paired culture results where blood samples were drawn from separate sites at the same time. So these are essentially simultaneous cultures in 269 babies. Each culture bottle received at least 1 milliliter inoculum. So these were adequate volumes of blood. And what they found was that 247 were negative in both bottles and 22 were positive in both bottles. That is, the concordance rate was 100% in this series. And this is very compelling evidence that those low density bacteremias, which should give discordant results if they were present in this population, must be very, very rare. And if we look at the probability of something not happening when you observe a series of patients and divide that by the number of positive results here, this indicates that the prevalence of low density, ultra low density bacteremia in babies with neonatal sepsis must be less than 2% of those who have blood cultures. So blood cultures, with the caveat that at least 1 ml of blood is placed in the culture bottle, have a very high sensitivity. And it's actually just a myth that blood cultures often fail to detect neonatal bacteremia. Now, at this point, you will note that I'm being very careful in saying neonatal bacteremia and not neonatal sepsis, because I think there's a very important difference. But if a bacteria is circulating in the blood and you draw a blood culture with at least 1 milliliter inoculum, the probability of recovering that organism is very, very high, essential certainty. So how do we go about getting a false negative blood culture? I'll give you 2 or 3 ways that we can achieve that result. The first approach to that is unfortunately very, very common, and that is that we might use an insufficient amount of blood. If we are looking at 1 milliliter samples, we can see that there's a 95% chance, a 99% chance as shown on the earlier slide, and that goes down to 95% chance of recovering the organism if we use only 0.5 milliliter samples. But if we're operating at a bacteremia density of only 2 colony forming units per ml, that drops down to 60%. So we've got nearly a 50% probability in that circumstance, a half ml sample of blood with 2 colony forming units per ml placed in the bottle that will fail to detect the bacteremia. So false positives become much more prevalent as we use smaller volumes at the lower margins of bacteremia density that we actually see in babies. So the minimum inoculum that has to be used in the blood culture is 1 milliliter. We really can't go lower than that. By the same token, the idea that we can use molecular technologies to detect bacteremia in samples that might be much smaller, say 50 or 100 microliters, is really not consistent with this information from the Poisson distribution. There's a high probability that at the lower end of the concentrations that have actually been observed in babies, that simply on a stochastic basis, there will be no organisms in those tiny samples. So the message from this is that we should skip ancillary diagnostic tests like the CBC, C-reactive protein, procalcitonin, and so forth, so that we don't have to skimp on the inoculum that's put into the blood culture bottle. So when you get a small volume of blood, which is typically the situation, our nurses are pretty good about squeezing blood out of babies or drawing it from their veins. But if you only have on the order of 1 milliliter, invest that all in the blood culture and don't waste it by spending it on ancillary diagnostic tests. The second way that we can get a false negative blood culture is to draw the blood too soon. And a common pattern of practice is that at the time the baby is born, or perhaps even before, risk factors for sepsis are identified. So as soon as the doctors can get their hands on the baby, they draw a blood culture, as shown on the left here. And then at some time later, shown in the gray, there is onset of bacteremia. The baby is not yet sick. Sometime after that, the baby develops clinical signs of illness. And that is the point at which it's appropriate to draw the blood culture. If you draw the blood culture before the baby is ill, the baby may not yet have become bacteremic. The negative blood culture is not informative about the status of that baby by the time he or she has developed clinical signs of illness. So it is essential after the baby becomes sick to draw the blood culture at that point. And there is actually no reason to do the so-called screening blood culture based just on the presence of risk factors. Now, we've been managing babies at Stanford, certainly those 34 weeks or greater, by observing them for the clinical signs of illness, whether they have risk factors identified or not, and reserving blood cultures only for those babies who develop signs consistent with bacterial infection. At that point, we draw the blood culture and initiate antibiotics until the results of the blood culture become available. So don't draw the blood culture too soon. Wait until there's actually a reasonable probability that the blood culture will be positive. I think a reasonable paradigm for deciding whether you think there's a reasonably high probability of bacterial infection is whether you're going to start antibiotics. If you are, then you think that there's a reasonable probability that the blood culture will be positive and it can be drawn. If you're not, you're betting that the blood culture will be negative, and that's not the time to draw the blood culture. A third way to get a false negative blood culture is to check the results too soon. Here's some data, recent data just from the last 2 or 3 years, showing the cumulative proportion of positive blood cultures as a function of time after the culture is obtained and placed in the incubator. And you can see that by 36 hours, 94% of the cultures are positive, and by 48 hours, 97%. If you look at this 6% of cultures that turn negative after the 36-hour time point, many of these are with organisms that are probably skin contaminants, staph, epidermidis, staph hominis, and so forth. So if you do check the blood cultures at only 24 hours, a much lower percentage of these will be positive. So only 68% of the true positive cultures are positive by 24 hours. And that overall is a bit too soon. Now, there's good data from Dr. Canty's work in Texas that if you stop the antibiotics after 36 hours of incubation based on negative cultures, that is safe and the babies do not develop breakthrough or recurrent bacterial infection subsequent to that. That group of workers has also noticed that if you're looking at the organisms that are of greatest concern to those of us in high-income countries, group B strep and E. coli, that essentially 100% of those cultures will be positive by 24 hours, and that might be a reasonable time to consider stopping antibiotics. If you work in areas, as many of you do, where group B strep and E. coli are not the dominant organisms, 36 hours is going to be a much more reasonable duration of incubation, but you probably don't need to go all the way to 48. But you certainly don't want to stop the antibiotics based on checking the blood cultures too soon. There are some things that do not result in false negative blood cultures, and there's a lot of belief that these things may do so, so I'll address those briefly right now. The first of these is, well, the blood culture sat around, it was on the counter waiting to be picked up in the nursery, and then it went down to the laboratory and it sat on the counter there, and maybe it had to be put in a courier van and shipped over to a central laboratory, and it took 8 or 10 or 12 hours from the time that the sample was obtained to the time that it actually went into the incubator. So here's data that looks at the effect of the time to machine entry, shown on the horizontal axis, to the time to positivity for sham cultures that were inoculated with E. coli or group B strep at low concentrations, less than 1 CFU per ml, or at higher concentrations, more than 10. And we can see that the time to positivity did in fact increase with increasing duration of time from 3 to 8 to 15 hours, from 30 minutes to 8 to 15 hours after collection of the specimen. But this did not move the time to positivity outside the range that we had just discussed of the cultures turning positive within the first 36 hours. So for these two common pathogens, at least, 36 hours from bottle inoculation to result interpretation should be sufficient, at least if the delay in placement into the incubator is no more than about 16 hours. The second thing that people believe gives false negative culture results is interpartum treatment with antibiotics. Of course, we've encouraged our obstetricians to try to prevent neonatal infection by giving interpartum antibiotic treatment to women, certainly those who have chorioamnionitis and are at risk for that reason, but also prophylaxis for group B strep colonization. Often when the baby is ill and the blood culture comes back negative, the comment from the neonatologist is, yeah, but baby got antibiotics in utero, and that's going to suppress the results of my blood culture, but he was still bacteremic. If that were the case, we would expect that treatment with interpartum antibiotic prophylaxis should prolong the duration required for the blood culture to turn positive because there would be a reduction in the density of the bacteremia. Fewer colony forming units results in a longer time to the culture being detected as positive and reported out by the machine. And we can see in this data that there's no difference on the left in the duration of the time to positive results in these essentially a Kaplan-Meier curve between babies who were exposed and those who were not exposed to interpartum antibiotics. And similarly, data from Sarkar showing no difference in the time to positivity between the no IPAP and IPAP groups. So interpartum antibiotic prophylaxis doesn't increase the time to positivity, but it does effectively prevent neonatal bacterial infection. So in this situation, you can still trust the result of your blood culture. So this brings us to the question at hand: what is this construct called culture negative sepsis? I think that this is really a misnomer, an incorrect label for an ill-defined and likely very heterogeneous group of infants who are sick, but who do not have evidence of bacteremia. Often, it is just an illusion that there's actually a bacterial infection, and this serves as an invitation to prolonged antibiotic therapy that really cannot be beneficial. As Karen Popolo has pointed out, if the baby doesn't have an infection, antibiotics can't possibly help him. This is also an example of availability bias. One of the common diagnostic cognitive errors that we as physicians are prone to, where the diagnosis of sepsis is convenient for us. So we say, well, we know that the data is not perfectly consistent with it, but we think the baby's septic anyway. And because of that, we don't have to look further to figure out what's actually going on with the baby. And this results in failure to make and appropriately treat the correct diagnosis. So over the next few minutes, I'd like to talk about how designation of this circumstance as blood culture negative conditions rather than culture negative sepsis is more likely to lead to decisions that are useful in management of these infants. Well, why does it matter? The first reason, and the most important, is that these babies have worse outcomes than infants who don't have sepsis. In the left-hand column here, there's data from Switzerland where in these small babies, 24 to 28 weeks gestation, they really didn't see any difference in BPD, retinopathy of prematurity, or neurodevelopmental impairment at late follow-up. But in the United States experience, in a similar group of very small babies, the adjusted odds ratios for mortality, BPD, retinopathy of prematurity, periventricular leukomalacia, and death or neurodevelopmental impairment, and marginally for neurodevelopmental impairment itself, were all in the direction of worse outcomes for babies who had culture negative sepsis as compared to babies who did not have the diagnosis of sepsis. Similar data were obtained from China in a more recent cohort where BPD and periventricular leukomalacia were found to be more common in these cohorts. Unfortunately, there's no evidence at all that antibiotic treatment averts any of these adverse outcomes. So the question is, what's really going on with these babies and what can we do to help them? So the second reason why this matters is that more antibiotic treatment may not reduce hospital stay or mortality. This has been addressed by a couple of series. The first of these from Dallas in an interrupted time series analysis. So this is Dr. Canty's work, where they compared a baseline period to a period where they introduced a protocol for early discontinuation of antibiotics when the cultures were negative in this study at 36 hours of age. And they found that by taking a more systematic approach, they could reduce the increase the number of babies who received fewer than 5 days of antibiotics from only 31%, that is 2/3 of their babies got more than 5 days of antibiotics, and they were able to increase that to 62%. So only about 1/3 of the babies got longer courses. Now, in this study, they found that there was a statistically significant increase in the length of stay from a median of 7 to a median of 8 days, which their subgroup analysis and post-hoc trying to drill into this didn't reveal why this might be the case. There wasn't a clear explanation. The difference here is small, however, and it's statistically significant because of their very large sample size and the fact that they used a non-parametric Wilcoxon test to compare these groups. So statistically significantly, but clinically probably not terribly relevant. And that they saw that there was no difference in the mortality, 6.1 versus 6.8%, among the subgroup of their infants who were less than 32 weeks gestation. In a second series that is a little bit more current temporally, 2016 to 2019, of infants less than 35 weeks in Chicago, they looked at retrospective matched cohorts, and they compared babies with suspected sepsis who were exposed to antibiotics for less than or equal to or more than 3 days. And they found that the babies with the longer exposures had longer duration of stay, 48 versus 35 days at the median. And they also found that the mortality was about double, but because of their relatively small sample size of only 150 babies, that was not statistically significant. So what we don't know from this is whether the longer duration of antibiotics led to the longer length of stay, or the fact that the baby was sicker, resulting in both the longer length of stay and the longer duration of antibiotics. This may be a correlation rather than a causal relationship. So both the sequelae and benefits of antibiotic treatment in this setting remain very poorly defined. And there's a rich opportunity for investigation available for any of our younger colleagues who might want to pursue this. So Dr. Canty, in his really wonderful commentary from just over a year ago, pointed out that these clinical scenarios can be diagnosed as culture-negative sepsis, so they could be divided into those who probably had bacterial sepsis and those with non-bacteremic diseases. So under probable bacterial sepsis with a negative culture, there may be insufficient inoculant volume, which we've talked about. Pre-treatment, probably not a real phenomenon. Premature culture, we talked about. And then there are some organisms which are difficult to culture, or there may be ultra-low density bacteremia. And we talked about the very low probability of existence of ultra-low density bacteremia in our neonatal population, so I don't think I'll say much more about that. And then there are a variety of non-bacteremic diseases that we'll look at in more detail momentarily. So in that same paper, Dr. Canty presented an equation that described the probability of culture-negative sepsis. And I was really fascinated by that, but I thought that I would reframe that a little bit. I love equations myself. So if we look at the babies in whom sepsis is suspected, but blood culture results are negative, we can divide them up into babies who have no disease, those that have bacterial infection, and note that I'm saying bacterial infection, not bacteremia here, those who have other infections, non-bacterial, and those who have non-infectious conditions. And then the equation that I would write, which is leveraged off of the Canty's suggestion, is what is the probability that antibiotics will be beneficial in a baby who is ill, but the blood culture is negative? And that's the sum over all of these conditions of the probability that the baby has a particular diagnosis given their clinical condition, times the probability that the blood culture will be negative if they have that diagnosis, times the probability that antibiotics will be affected if they have that particular diagnosis. And you will notice that the probability that antibiotics will be affected if there is no disease, if there are other non-bacterial infections, or if the process is non-infectious, is 0. So the equation at the bottom here simplifies quite nicely. What is the probability that the diagnosis is bacterial infection? What is the probability that the blood culture will be negative, which is low if the baby has bacteremia, but may not be with other conditions, as we'll talk about? And what is the probability that antibiotics will be effective? It's important in this last term to note what is the probability that the antibiotics that we initially choose to use will be effective. And an example of how this distinction is important might be in the preterm infant whose mother has received an extended period of latency antibiotics to suppress the development of chorioamnionitis because she's got ruptured membranes. And then the baby goes ahead and delivers at 27 or 28 weeks anyway. If we treat that baby with our standard WHO recommended ampicillin and gentamicin, but the baby is colonized with an extended bacterial resistant E. coli, those antibiotics are not going to be affected. So this term is going to be essentially 0, given the organism that the baby is infected with. On the other hand, if that baby was delivered prematurely, primarily for maternal indications, happened to be colonized with group B strep, the ampicillin will be highly effective, and this term will be essentially 1. So let's look at each of these categories in a little bit more detail. So first, bacterial diseases where the culture is going to be negative can be divided up, I think, into these 3 specific groups. There may be fastidious organisms, including the obligate anaerobes, and there are a few organisms that really do not grow well under anaerobic conditions, but these are relatively unusual. Because obligate anaerobic infections are relatively unusual in babies, my recommendation is to invest all of the blood in the aerobic bottle, and the facultative anaerobes will grow there. The few obligate anaerobes will still potentially be missed. Ureaplasma and mycoplasma, of course, can't be grown in routine blood culture media, nor can chlamydia. Neisseria gonorrhea, unfortunately, still quite a rampant infection in our populations, is a relatively fastidious organism and isn't routinely recovered with reliability with routine cultures. And brucellosis is another fastidious organism which may be cultured, but the yield there is going to be lower. Organisms that are simply not culturable, Treponema pallidum. I don't know what's going on in the part of the world where all of you work, but here in California, we're having a resurgence of syphilis and are seeing many more cases of congenital syphilis than we had seen historically. There's been a huge increase in this disease in our population in the last 5 years or so. Unusual organisms, including Snathia, Leptotrichia, and Leptospirosis, cannot be cultured and will not be recovered from the blood culture. Finally, and this is a large contributor to this population in my experience, focal bacterial infections may not be associated with bacteremia. We know, for example, that with pneumonia, about 40% of the infants who have an infiltrate on chest X-ray, respiratory distress, and a tracheal aspirate from which bacteria are recovered at the time of initial intubation, when the trachea should be sterile, will not have a positive blood culture. We know that a substantial portion of the babies with culture-proven bacterial meningitis, somewhere between 15 and 50%, do not have a positive blood culture. Urinary tract infections are even less commonly associated with bacteremia, but we don't really know in the neonate whether the problem there is that we're overdiagnosing infection in the urinary tract or under diagnosing bacteremia, or there's a low prevalence of bacteremia. Certainly the situation of urosepsis, where both the urinary tract and the blood are infected, is a real phenomenon. There's very little data on the prevalence of bacteremia with osteomyelitis or septic arthritis, cellulitis, omphalitis, and finally, Bordetella pertussis is not associated with bacterial infection or bacteremia from which you can recover the organism. And in all of these cases, specific diagnostic tests are required, and standard antibiotics are likely to be ineffective. For some of the conditions on the right, the standard antibiotics may be appropriate, but if you're dealing with meningitis or osteomyelitis, you may need to use larger doses and for longer periods of time. Second category is babies who appear sick, but actually really don't have diagnosable disease. And this includes babies with risk factors only. In this situation, the baby may have multiple maternal risk factors identified: prolonged rupture of membranes, interpartum fever, GBS colonization, whatever. But if the baby looks well, they may in fact not be sick. And in that situation, antibiotics aren't going to be helpful. And as I mentioned, for our 34-week gestation and older infants here at Stanford, we are not treating with empiric antibiotics for risk factors only. Babies who are immature may show signs consistent with sepsis, including very nonspecific things such as poor feeding or apnea events. These are developmental in nature and do not reflect sepsis. Unfortunately, it can be very difficult to distinguish the babies in whom this is simply a developmental phenomenon from those who are developing bacterial infection and who may be bacteremic. But here, of course, we're saying that the blood culture is negative. And if the blood culture is negative, we should be confident that we can stop antibiotics for those indications. There are a number of transitional events that can mimic sepsis, the most common being transient tachypnea. I've had lengthy discussions with Dr. Poland, my friend and colleague from Columbia, about this situation. And I think our consensus, to the extent we're able to achieve one, is that transient tachypnea is a process that starts out essentially immediately after birth, may remain stable for a couple of hours, but then progressively improves. Whereas babies who have pneumonia or respiratory distress as a result of bacterial infection either fail to show improvement by 6 hours of age, or they show signs of worsening respiratory distress earlier on. And in those situations, diagnostic evaluation and initiation of antibiotics may be appropriate. Babies may also present with hypothermia, hypoglycemia, and jaundice. These findings have a low positive predictive value for the presence of bacterial infection. And unless there's a failure of response to more specific therapies, antibiotics are unnecessary in that situation. And finally, there are a number of things that we do to babies that may make them appear ill. Hypermagnesemia is an increasingly frequent observation. Not only are we giving magnesium to mothers for management of their preeclampsia or hypertensive disease of pregnancy, but we're also using it now for neuroprotection in our preterm babies. And the babies who are hypermagnesemic are often hypotonic, they feed poorly, they may have apnea, and they may need support for that reason. So they can actually look as though they're quite ill. Opiate exposures. The opiates that are used for mothers, I think, are being used more judiciously these days. And the tendency is to use shorter-acting opiates, which fairly quickly disappear from the baby's circulation, drugs like fentanyl. So if there has been an opiate exposure, particularly with a longer-acting agent like Dilaudid or Demerol, that is something that should be considered, and Narcan to reverse that may be helpful. In our intensive care unit, we see babies having apneas with exposure to prostaglandin to keep their ductus open. If they have congenital heart disease, that is not sepsis when they have apneas or fevers in association with that medication. And later on, as we begin immunizing babies, responses with fevers, irritability, and perhaps poor feeding may be a manifestation of this non-disease circumstance. Next to the category of infections which are non-bacterial in nature, which of course we can divide up into fungal, parasitic, and viral. The fungal diseases, most commonly in the NICU, Candida. We are seeing much less Malassezia furfur these days. That's a fungal organism that is associated with the delivery of intravenous lipid solutions. With the more modern intravenous lipid solutions that we've been using for the last 10 or 15 years, that organism seems to be much less common than it was 20 or 25 years ago. Aspergillus is a soil fungus that can be airborne and can infect babies. And this is particularly seen in places where immunocompromised newborn infants are exposed to disturbed soil. So agricultural areas, construction sites, things of that sort. But that can definitely be a cause of pneumonias and brain abscesses in those babies. Parasitic disease, I think those of you in the audience know these conditions much better than I. Certainly malaria is more familiar to you than it is to me, but also toxoplasmosis, of course, Chagas disease and Babesia, the latter two being tropical conditions and again being more familiar to you than to me. For all of these parasitic and fungal conditions, the specific diagnostic studies have to be targeted to the particular organism, and of course antibiotics will be ineffective. There are a number of viral diseases, the respiratory viruses, of course, including respiratory syncytial virus, now COVID, adenovirus. Enterovirus is a very, very common organism infecting babies. I believe that enterovirus infection in mothers who are slightly preterm, 34, 35, 36 weeks gestation, may trigger the premature onset of labor. I don't think it triggers premature onset labor at 26, 27, 28 weeks. But these babies who are closer to term, delivered to mothers who may not realize that they have an enterovirus infection, may have very significant enteroviral disease acquired from their mother that develops over the first few days after birth. The manifestations may be as simple as just an enteroviral exanthem or as complex as disseminated enteroviral disease with pneumonia, liver failure, and meningoencephalitis. Cytomegalovirus, of course, is a very common organism, affects a variety of different organ systems. And it's important to be aware of that one because there is a specific treatment that can reduce the risk of long-term morbidities in babies who have that organism. Coronavirus I've mentioned, and finally herpes simplex virus can, of course, also be a manifestation, be manifest as what appears to be neonatal sepsis. And for that, there's also a specific treatment. Finally, there are a number of non-infectious conditions that can make a baby appear to be ill, but which are not associated with positive blood culture because bacteremia is not a part of it. The hemodynamic conditions, coarctation of the aorta and shock or focal ischemia can result in poor peripheral perfusion, a baby who's lethargic or obviously quite uncomfortable, and may be associated with lactic acidosis, which makes you think about possible septic shock. Those conditions require specific treatment. Coarctation can be managed quite nicely with a prostaglandin infusion, but antibiotic therapy is not going to be helpful there. Respiratory diseases, RDS in our preterm population, aspiration pneumonia in our term population, will also cause the baby to have needs for respiratory support, but not a need for antibiotics. A number of metabolic diseases can be associated with a septic appearance, certainly all of the lactic acidemias, the fatty acid oxidation disorders, hyperammonemia of all sorts, but certainly including the urea cycle disorders. So those primary metabolic disorders of intrinsic metabolism, those babies look and act sick and may look for all the world as though they're septic. Cortisol deficiency is essentially endemic in our tiniest babies. And of course, babies with congenital adrenal hyperplasia need cortisol replacement. So this is a more common problem in our small babies than I believe most of us are alert to, and it's something to consider. Certainly when you see a baby who has respiratory distress, is hemodynamically unstable, the chest X-ray shows bilateral consolidations, typically the heart appears to be small. These babies may not need antibiotics, but they may need cortisol. And finally, a condition that I've just learned about recently, and again, I think is probably a lot more familiar to you than it is to me, but beriberi thiamine deficiency, which of course is a dietary deficiency that goes along with subsistence on a diet that is essentially exclusive processed rice or dominantly processed rice, where the mother has inadequate thiamine levels. And I've just learned from people from your community, those of you who practice in South Asia, that this condition is actually the most common cause of neonatal pulmonary hypertension in your part of the world. So a little bit of thiamine will go a long ways there. Antibiotics aren't going to be helpful. And finally, there are a number of immune-mediated conditions: neonatal lupus, gestationally associated liver disease, hemophagocytic lymphohistiocytosis. I have to practice saying that. And finally, the isoimmune neutropenias or thrombocytopenias all have laboratory and, in some cases, clinical manifestations consistent with neonatal sepsis. But specific diagnostic studies are required for these, and antibiotics are not effective. So that leaves us with a bunch of unanswered questions. What unrecognized conditions are responsible for blood culture negative sepsis-like illnesses in newborn infants? There are essentially no surveys where a comprehensive diagnostic evaluation has been routinely performed in a population of babies who have blood culture negative results, but who appear to be septic. So we don't really know what from that long list of possibilities that I have just given you is most likely and which are least likely, and how to stratify the risk and how to sequence our diagnostic evaluation accordingly. What outcomes are associated with these blood culture negative conditions? I showed some preliminary data that suggests that babies with blood culture negative septic-like conditions have worse outcomes. But the answer is really not in. We don't know overall what the spectrum of outcomes are, and we don't know what the predictive factors are for adverse outcomes. What interventions can modify those adverse outcomes? Does empiric antibiotic therapy do so? Interestingly, we don't know the answer to either of these questions. Antibiotic therapy in the absence of bacteremia is not likely to be helpful, but if you have a focal bacterial infection, such as osteomyelitis or bacterial meningitis, it may be actually quite essential. Is there such a thing as partially treated neonatal sepsis? That is, it's culture negative, but it will recrudesce unless treated for a longer course. This belief is really the driving force behind our common practice of, I know the culture is negative, but I'm going to continue the antibiotics because I think the baby has bacterial infection. And we need better data to support that practice. With the exception of focal bacterial infections not associated with bacteremia, which we should search for assiduously, treatment with antibiotics are not going to improve outcomes, and stopping the antibiotics is not going to lead to recrudescence of a bacterial infection. So we need to know, how can focal or occult bacterial infections more reliably be recognized or excluded? And here's an opportunity for the application of new technologies, perhaps the use of biomarkers or metabolomics, proteomics, things of that sort, for allowing us to identify the babies who do have bacterial infections, but who are not bacteremic. And finally, and perhaps most importantly, how can we gain confidence that it is safe to discontinue antibiotic therapy when blood culture results are negative? I think Dr. Joseph Canty in Texas is taking the lead on this. They're doing studies based on the SCOUT trial, where they're systematically demonstrating that stopping antibiotics when the cultures are negative is safe. Now, because we're dealing with a low prevalence condition, it's going to take a large sample size, a large number of infants managed with that approach before we can be confident in the safety, but I think that that will be coming. So all of these questions are opportunities for research. They can all be done without, or most of them can be done without access to esoteric technologies, because these are based in our nurseries, which are in fact our clinical laboratories where we can do good science. So thank you for your attention.
Thank you, sir. That was an amazing lecture going through all the aspects. Now I'd request the moderators to kindly initiate the panel discussion.
Arjit, you are muted. You can start. You are muted, Dr. Arjit, you are muted.
Sorry. So nicely and elegantly, elaboratively, Professor Benitz explained us the things. So we're all delighted. So there are a few questions from the audience. So the first one is, what is the effect of prior antibiotic before sending blood culture on the culture yields?
I'm sorry, I was having difficulty hearing the question.
What is the effect of prior antibiotics on the yield of blood culture?
The effect of prior antibiotics on the yield of the blood cultures.
Yeah,
Right.
Yeah, this is an issue that Canty has addressed. Certainly, we think that antibiotics result in fewer positive blood cultures. How long that takes, we're not really sure, but it may happen very quickly. I know personally of an experience where we gave antibiotics to a baby who was doing very poorly, and we wanted the antibiotics on board right away, and drew the blood culture less than an hour later. And the blood culture was sterile, but the endotracheal tube aspirate showed sheets of group B strep organisms. So we know the baby had group B strep pneumonia, and less than an hour of treatment with ampicillin was enough to sterilize that massive infection. Unfortunately, that baby had overwhelming infection and died. So we know that phenomenon can happen. It can happen fairly quickly. Now, the question is, if the dose or two of antibiotics that the baby has received before the blood culture is done is sufficient to cure the bacteremia, did it cure the infection? And that's a question that we don't really have an answer to. And Canty would argue that to a large extent, yeah, the culture is negative, the infection has been cured, you don't need to treat more. And that leads into the question of how many days of antibiotics are necessary. Maybe 3 days is enough, period. There are some studies that look at the difference between 4 days and 7 days. Some look 7 to 10, but we don't really know what the required duration of treatment is. And when you look at that body of literature, it is confounded by the fact that many of the babies who are treated with shorter durations of antibiotics didn't have infection at all. So of course you can treat with fewer days of antibiotics because they're not infected. And one of those papers, for example, came from one of my own partners, Alistair Phillip, who looked at babies with pneumonia at one of our community affiliated hospitals. And he found that they could shorten the duration of antibiotic therapy to the time at which the C-reactive protein returned to normal. So the mean duration of treatment in that series of babies, I think they were about 120, was only about 4 days, and they did well. But if you look at that population, most of those babies never had an elevated C-reactive protein. So they were never infected. So they didn't need to be treated at all. 4 days was 4 days too many. So it's a perceptive question. And when you start to drill into this, you can see how quickly it becomes really complicated.
Thank you, sir. So the next question is, do you advocate practice of sending blood culture on admission to all the babies who have risk factors for early onset sepsis?
No. We, for many years, had a practice in compliance with the national guidelines that if mom had chorioamnionitis, that the baby should be immediately evaluated and treated. And we were essentially treating 100% of those babies. In 2015, we transitioned to treating only the babies who showed clinical signs of illness, and our exposure rates in our chorioamnionitis exposed babies, exposure rates to antibiotics dropped initially from 100% to about 12% and then to 5%. And we're still continuing to treat about 3 to 5% of our chorioamnionitis exposed babies with empiric antibiotics, but we're only doing blood cultures on the babies at the time that they show clinical signs of illness, and antibiotics are going to be initiated. What we've found is that the vast majority in the now 8 years of experience that we have with that approach, almost all of the babies who have bacterial infection are symptomatic right at birth. We have had a few babies who became symptomatic over the next 24 hours or so, and they have all been recognized as not behaving normally by our bedside nursing staff, who we've trained to do a very simple limited evaluation based on the work of Alberto Berardi in Italy, where we look to see, does the baby appear well perfused? Are there signs of respiratory distress? Is the baby feeding normally? And if the baby passes those, the nurse assists mom with breastfeeding, and if not, the pediatrician is called. Then we have the luxury of having a pediatrician in-house. We can go and examine that baby straight away. And all of the babies, I think we've had 9 or 10 over that period of time with culture-proven bacterial sepsis. All of them have revealed themselves as being clinically ill. So no, I'm not a believer in the whole construct of a screening bacterial culture. For many years, that's always been a head scratcher for me. If you think that the probability that blood culture is going to be positive is reasonably high enough to justify sending it, why aren't you treating that baby? And if you don't, why are you sending a blood culture that you think is going to be negative? It just doesn't make sense to me. So wait until the baby shows signs of clinical illness and then invest in a much smaller number of blood cultures. It'll be much more cost effective. The yield will be higher, and your treatments will be better focused. We're still going to end up treating a lot more babies than are actually infected. And right now at Stanford, despite our major efforts to reduce our antibiotic exposure, we are still treating about 100 babies for every one that actually has positive blood culture. Now, what happened? You know, it used to be that we were only treating 40, and we instituted a policy to try to reduce our antibiotic use, and the ratio went up. And what happened was that the prevalence of early onset sepsis went down by about 10-fold because of obstetrical interventions. Our OBs are doing such a good job of preventing infection in our neonates. Thanks to them. I love our OBs. But the result of that is that the ratio of treatment to true disease has actually gone up because our proportion of true disease has gone down so dramatically, which is exactly what we want.
Thank you, sir, for the very elaborate answer. So we have a very interesting question which has come up. Dr. Daniel Alejandro has asked, do you have an advantage if you inoculate more than 1 ml of blood in the culture? You told 1 ml is the ideal specific.
Yeah.
So do you have any advantage of more than one?
Yeah, you know, the argument has generally been on the other side. Can you get away with less? Because blood is so hard to get from these babies. There is some advantage to going to a higher yield, but what I showed you is that the prevalence of low density bacteremia in our patient population is really low. It turns out this doesn't apply to older kids, and it certainly doesn't apply to adults. You know, we all learned in medical school that if you have an adult with fever of unknown origin, you've got to draw blood cultures 5 or 10 ml, and then you got to come back in 6 hours. You got to do it again. You got to come back in 6 hours and do it again. Because ultra low density bacteremia in adults, particularly those with endocarditis, is extremely common. So that's not the case in our population. So I don't think that there's a huge advantage to trying to get really large volumes. Of course, we don't want to go to 5 or 10 ml because that's a huge part of our baby's blood volume. If you can get a little bit extra, yeah, go for it, but probably not more than 2 ml. And if you can get one and do that consistently, I would consider you to be practicing at a very high level.
Thank you, Dr. Benitz. And how many more questions you will be able to take, Dr. Benitz?
I have an appointment in about 6 hours.
Oh, 6. Okay. So yeah, okay. So we'll try to finish.
By then, I think all of you will want to be in bed.
Yeah, true. So okay, we will try to finish as many questions as possible. Dr. Bharat is asking, can we assume that for late preterm with risk factors, we need not include blood culture if asymptomatic?
Yeah, to a certain extent. For the late preterm, I'm very comfortable. If we're dealing with babies that are more than 34, 35 weeks, that's been a part of our practice now for 8 years. And I'm quite confident that that's safe. Not just the 40,000 babies or so that we've managed here at our primary site, but at our satellite hospital, the one where Dr. Phillip used to work, has another 25,000 babies or so in their experience. There's experience from Norway, from actually 2 different centers there that have adopted this approach, and there's fairly extensive experience. I think the overall experience in Italy is now in the range of 100,000 babies. So I think that in the late preterm and full-term babies, the approach, as my wife says, just look at the baby, is a good one. It's safe. The trick there is that somebody actually does have to look at the baby. And there's a resource utilization issue. And if you're in a place where you can't have a trained practitioner with at least the minimal skill set to look at a baby and say, yeah, this baby looks okay, or no, this baby doesn't. You know, that can be a community health worker, it could be a nurse midwife, it can be a bedside obstetrical nurse. It doesn't have to be a doctor, but somebody has to be looking at the baby and checking to be sure that they're not tachypnic, they're not badly perfused, they're not hypotonic, they're not lethargic, they're feeding okay. And if they hit those marks, those babies are at very low risk. The place where things become difficult is when you go below 34 weeks. And Sagari Mukhopadhyay and Karen Popolo in Philadelphia have 2 papers that have identified low-risk babies. So the preterm infant that is born without rupture of membranes, without signs of chorioamnionitis, for maternal indications, of course, usually is maternal hypertensive disease. Those babies are at very low risk, and you don't need to initiate antibiotics on those babies, even though being premature, a lot of them are going to have respiratory distress. So I think that's a start. It turns out about 1/3 of the babies meet those low risk criteria. So that's another opportunity for better antibiotic stewardship. We've been trying to take advantage of that. I think our crew for the last 3 or 4 years has been pretty good in that population, but that's an area where we're still acquiring comfort.
Thank you. Dr. Kedar wants to know if there is a delay in processing blood culture, how and where to keep the bottle.
How warm to keep the bottle?
Where do you store the bottle before, if there is a delay in processing the blood culture?
Usually when there's a delay, it's not a matter of having a place to store. If you know, for example, that your courier is only going to be coming by every 12 hours to pick up the specimen to take it to the laboratory, putting it in an incubator at 37 degrees would be great. So having a warm cabinet, a lot of us have blanket warmers. You can put a box in your blanket warmer and drop it in there and keep it warm. That's better than sitting out on the counter, which, here in our air-conditioned buildings, we run at 20 to 22 degrees. So bacterial growth is slower, as I showed you on that slide, but keeping it warm if you can. The practice patterns in the States vary quite a bit. One of our large integrated healthcare systems here in Northern California, the Kaiser system, the home of the Kaiser sepsis calculator, does all of their bacteriology at a centralized laboratory in Oakland. So the cultures that are obtained in any of their nurseries go to their laboratory. I'm not sure exactly what they do with them, but I think that they're kept at room temperature until the courier comes and takes them over to Oakland. And that, my understanding, is typically happens early in the evening. So between 6 and 8 in the afternoon, they come pick up the cultures and they get into the incubator. But they're able to do that pretty routinely, so the delay is not more than the 12 to 16 hours that I showed you on that slide earlier, and it doesn't substantially prolong the time to positivity. But if you're dealing with different circumstances, keeping it warm if you can. If not, then it may be that you need to increase the incubation or the time from sampling to the time of interpretation to 48 hours. But that would have to be based on local data.
Thank you. Dr. Parthasarathy wants to know what type of culture method was used in all these studies, like back-type or older traditional culture methods. What was the type of culture method?
All of the data that I showed you in my slides is with the BACTEC device or something that's similar. One of the slides used the Versatech, but almost all of these use the BACTEC technology. Yeah, the older technologies, I remember in the days when I was in medical school, you remember you held up the bottle and you shook it a little bit and you decided whether it was cloudy or not. That was not a sensitive assay. So, yeah.
Okay.
Relied on that.
Thank you, sir. Arjit? You have to unmute. Arjit. Unmute.
Yeah. So the next question is about many times where the CSF cell count and proteins are elevated, but how to approach those kind of scenarios? Should you treat them as meningitis in both the scenarios where the blood culture is negative and when the blood culture is positive?
Yeah, it's good to hear that you guys grapple with the same nightmares that I grew up and continue to grapple with my whole career. Here's the problem. You have a baby who's sick. And one of my aphorisms is that a sick baby could be septic and a septic baby could have meningitis. So we don't like to do LPs. There's something emotional that drives our reluctance to do that. It's not scientific, it's not rational. But we often will start antibiotics, send a blood culture, then start the antibiotics, so that sequence is correct. And then only when there are additional laboratory abnormalities or the baby shows behavioral changes that suggest meningitis or simply isn't getting better, do we come back around, maybe in a day or two, and we do a spinal tap, and lo and behold, the baby's got a high protein, a low glucose, a CSF pleocytosis, negative gram stain, and a negative culture. There's a new technology which is coming into practice, the BioFire panel, that is being used in this country a great deal. I'm sure it's available there in India. I don't know how much it costs, but because it's DNA detection and because the concentration of bacteria in the spinal fluid of babies that have meningitis is actually pretty high, The limited sensitivity issues with respect to using those technologies on blood are not nearly as applicable. It looks as though the biofire sensitivity is sufficient to be able to reliably identify bacterial infection. I think that's our escape hatch to get out of this conundrum. So when you get the specimen, set aside a little bit for molecular diagnostic techniques if those are available to you, because I think that's the only way we can get this resolved. Otherwise, we fall back on, our infectious disease people come and they say, we're sorry, you've got 35 red blood or white blood cells in that spinal fluid, and that's not normal for a 5-day-old baby. Well, arguably it might be, but they have a point. And then the protein is elevated. Okay, now you have another point, and we end up treating those babies for 2 or 3 weeks with antibiotics. And by 5 days, they might look perfectly fine. So they're a long time in our intermediate nursery plugged into an IV. It would be great if we could use the molecular technologies to get disentangled from that. I think that's our best bet.
Thank you, sir. So Dr. Aswin wants to know, how valid is the WHO guidelines to use ampicillin plus gentamicin as the first line of therapy in low and medium income countries?
Oh boy, I don't practice there, so I'm hesitant to comment. Those of you that practice in environments where the bacteriology is different have to make your own adaptations. I do watch the literature from around the world, the Indian Journal of Pediatrics and so forth has fairly regularly informative things. And sometimes I look at these papers about the bacteriology of the infections you guys deal with, and I go, man, I'm sure glad I don't have to work there because they're dealing with some nightmare bugs. So, I think the same thing is true in large swaths of Africa and Latin America. And I think it's very patchy. If you look around Mexico, there are some areas where the bacteriology looks a whole lot like California, and others where the prevalence of extended spectrum beta-lactamase is very, very high, particularly, in the rural areas there where antibiotic use has been quite uncontrolled. So I think you have to know what's going on in your local environment. I think the hospital-based antibiograms are extremely helpful. So your microbiology laboratory can really help you out with that. But those recommendations, maybe they're the best recommendation overall for a broad sample, but they're not targeted to individual places, and you have to individualize.
Thank you, sir. So Dr. Kedar again wants to know, what is the correlation between maternal urinary tract infection and neonatal sepsis?
Sorry, your audio broke up a little bit on my end. Can you give me that again?
So what is the correlation between maternal urinary tract infection and neonatal sepsis?
Oh boy, maternal urinary tract infection and neonatal sepsis. I don't know. If you look at the paper I did in 1998 with Dr. Gould and Dr. Drusen, we thought at that point that maternal UTI was a marker for risk. I'm not sure that it is. I think that moms who have group B strep present in the urine on their routine prenatal urine culture, what's done as screening, that's a marker of heavy colonization with GBS. And I think that, at that point, you basically don't need to do a screening rectovaginal culture. That mom's heavily colonized and she needs interpartum prophylaxis for GPS on that basis alone. But whether there's a relationship with the other more common causes of maternal urinary tract infections, E. coli in particular, and risk of infection in the babies, I think has really not been adequately studied. And I'm not sure that there's an increased risk there.
Right. Dr. Nalini wants to know, I am not sure whether I am getting it right. if blood culture negative in preterm with setback, that means we can stop antibiotics after 36 hours if backed up is negative.
Yes. Yeah.
You can stop.
Yes. If you send a blood culture and it's negative at 36 hours, you can confidently stop the antibiotics, knowing that the baby was not bacteremic at the time you sent the blood culture.
But if the back comes much more earlier. So if the back is negative,
the BACTEC result, the timing data that I showed you is with the BACTEC machine.
Yeah. So even then it should be 36 hours then.
Yeah, 36 hours is still the current standard. Now, if you're in a place where almost all of your infections are E. coli and GBS, then you probably could move to 24. And Joseph Canty in Texas, whose work I've relied on heavily, is currently running a prospective evaluation of stopping at 24 hours and trying to demonstrate that that is safe. The problem is that we're looking at a low prevalence condition, and within that, a low prevalence complication. So it's going to take a large sample size to be confident in that. But the data I showed you on time to positivity is with the BACTEC machine, and 36 hours should give you a good level of confidence across the full spectrum of organisms. The late positives, the Bacteroides and coagulase negative staph that grow after 36 hours are almost certainly contaminants and not true positive bacteremias. So the caveat and the reason for the last 4 or 5 slides in my talk is that you can stop antibiotics with confidence that the baby was not bacteremic. That means that you still have to look and make sure that the baby doesn't have a focal bacterial infection somewhere that's not associated with bacteremia. So as we were getting used to this, I was on rounds one morning with one of my very junior colleagues, somebody who I had trained as a resident and a fellow. And they had a baby that was 4 days old and was still on antibiotics and had a negative culture. But the baby was still on fairly generous CPAP, good oxygen supplementation, had infiltrates on his chest x-ray. And John said, "Bill, I'm really sorry. I just can't stop the antibiotics on this baby." And I said, "John, you don't have to apologize. What you're telling me is that this baby's got bacterial pneumonia and you're treating it. And that makes sense. And a lot of those kids don't have positive blood cultures. I'm with you." So before you stop antibiotics just based on the positive or the negative culture, make sure that you don't have a focal bacterial infection somewhere, because you don't want to fall into that trap. So judgment's difficult.
Thank you. Dr. Elizabeth wants to know, how long do you observe the babies with risk factors for early onset sepsis in whom you don't start antibiotics? That is, before being reassured that they are okay and we can discharge them. How long you have to wait?
Minimum of 24 hours, absolute minimum. Most moms here in the US will stay beyond 24 hours, usually typically closer to 48. When we introduced this practice back in 2015 and we were training our nurses to do this, they were very reluctant to take this on. This, we're busy nurses. The last thing we want is another task. We don't need more work. And we pointed out to them that somewhere between 40 and 60% of the babies who were in this low risk late preterm and term group who are going to get bacterial infection were going to fall ill on their watch out on the floor with their mom. They're not sick at birth. They get sick later. And they don't have risk factors. You can look at this information in like the reports of the implementation of the Kaiser sepsis calculator. And they said, "Oh my God, 40% of the babies are going to who are going to get sick are going to do it on our watch. What can we do?" And that helped a lot. And then what we were able to negotiate, we had been having them do frequent vital signs on babies with risk factors for the entire hospital stay. And we said, how about if we take that workload and we reallocate it so that you're doing close observation on all babies for the first 24 hours, and you'll do it every 4 hours. And they said, "Yeah, that's an equal swap. We'll do that." And then after implementation, there was a drift in practice. They said, it's too much trouble to do this on a schedule every 4 hours. How about if we just do it whenever we go to help mom breastfeed, which is every 2 to 3 hours in a brand new baby? And we said, yeah, more often is fine. We don't mind that. And they learned that the evaluation only takes like 20 seconds. It's very quick. And our documentation people put in a little window on our computer system so that's click, 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 and they're done. So even documenting it didn't take very much time. And then they said, wondering whether the baby's more than 24 hours, less than 24 hours old is just too much work. We'll just do it the whole time. So they do it until the baby goes home. But the rule that we've had is for a minimum of 24 hours. Only one of the babies who's developed bacterial sepsis, who was not obviously ill at the time of birth, became ill after 24 hours of age. And that baby got sick at about 36 hours.
Right. Dr. Jamie wants to know whether you can comment on the effect of unnecessary antibiotic use for possible early onset sepsis and the increased frequency of true late onset sepsis in a very low birth weight baby.
Yeah, Carrie Byington in Utah published a paper which I think bears paying attention to, where a very carefully performed analysis where they showed that babies who received interpartum prophylaxis in a risk-adjusted way were more likely to develop late onset sepsis than the babies who did not receive early treatment. And I think that's a potential adverse outcome of poor antibiotic stewardship. I think it might be real. There's a study going on in preterm infants right now called the NANO trial, N-A-N-O, that's run out of the University of Pittsburgh. Dr. Poland is one of the principals on that trial, where they're looking at randomizing preterm infants who are neither low risk nor high risk, but in the intermediate range, to receive ampicillin and gentamicin empirically or placebo. Both groups are getting a blood culture done. And they're only partway through enrollment for that trial. I hope they're able to finish that. But the prevalence of necrotizing enterocolitis and the prevalence of late onset sepsis is going to be one of the important endpoints there. So I think it is the low birth weight babies that are the risk population there, probably not so much in the term babies. But I think reducing early exposure to antibiotics may have a benefit with respect to late onset disease.
Ajay.
Yeah, Dr. Jami again wants to know that under the antibiotic stewardship philosophy, how long do you think we should treat these babies? 5 days? Or do you know any other experience with this length of treatment?
For babies with a positive culture?
Yeah.
Yeah, that's a really good question. That people have nipped around that a bit. There are some studies that look at 4 or 5 days versus 7 or 10. I don't think that the numbers there are sufficient, or that the diagnostic criteria for inclusion are sufficiently specific to be able to draw any real conclusions about that. The rule of thumb that we've used, one of my colleagues says that the duration of antibiotics treatment in neonates, in fact, in pediatrics in general in the United States, is based on football scores, not soccer scores where you only get 1 point for a goal. But here you get 3 points for a field goal, 7 points for a touchdown. So we treat for 3, 7, 10. So if it's not a football score viable number, we don't use it for duration of treatment. Go figure. But I don't think there's a lot of actual empiric science that guides how long is enough. So there's definitely an opportunity to try to define that. There was a paper many years ago, probably 30 years ago, from Toronto, where they treated babies with gram-negative meningitis for only 7 days. The sample size was not huge, but they found that they had no recurrence of disease gram-negative meningitis, predominantly E. coli, after only 7 days of treatment. And of course, routinely, we would treat that for 21. So 21 is probably too many. When I was a resident, we used criteria called Worley's criteria for deciding the duration of treatment of bacterial meningitis in kids, which meant we kept the treatment going until the CSF was perfectly normal. And often that would result in treatment for really long periods of time, 3, 4, 5 weeks. And then somebody had the idea maybe that wasn't really necessary, and we evolved towards the new standard of 10 days for gram-negative and or 14 days for gram-positive meningitis and 21 days for gram-negative meningitis, which was shorter than what we had been using previously, and there was no downside. So I think there's more opportunity there, but the short answer is we don't really know how much is enough. I'm not a big believer in the 4 or 5 day courses. And I think that my bias there comes from the fact that what I observe is that if someone is treating for 5 days, it's because they don't know whether the baby's infected or not. And if not, they would stop at 36 hours or not later than 3 days. And if so, they would treat for 7 to 10 days. So they split the difference and they treat for 5. And I think if that's just an indication of confusion, that's not useful. So some data would be helpful.
Thank you, sir.
Now,
So is there any correlation between PCR and blood culture for bacterial infections? And what is the role of PCR in sepsis, neonatal sepsis?
Oh boy, the role of PCR in sepsis. I think it's undemonstrated so far. I think the BioFire PCR for meningitis, because of the high density of bacteria in infected spinal fluid, is terrific. I'm really pleased to see that come into our diagnostic toolbox. It's going to help us a lot. The problem with PCR for bacteremia, even in neonates, you know, we're lucky. We're dealing with babies who have relatively high density bacteremia, as opposed to adults who have much lower densities. But the chances that you're going to find a single viable organism in a sample is small. And if you're using the kinds of volumes that are used for these molecular techniques, you may be using 50 or 30 or 20 microliters of plasma. That's not enough. Just, you know, Poisson says, forget about it. The chances that you're going to, in that tiny, tiny sample, get the organism that you're interested in is minuscule. So you've got to find some way to capture the single organism in a much larger volume, 1, 5, 10 ml. And I think that that's going to be an insurmountable problem for the time being. It's one of the reasons that Melio, the people that I've been doing some advisory work for, are interested in the neonatal population, because they understand Poisson math really well. And they realize that the higher density bacteremia in the neonate is a target for them, that they can actually get the organism circulating in a 1 ml sample. And they have technology that I'm optimistic is going to turn out to be helpful for us. It's not going to help the older population until they figure out some way to do bioconcentration. So the other place where PCR is really promising is in speeding up the recognition of presence of bacteria in blood cultures. So a lot of these technologies, you can incubate your blood culture for 6 or 12 hours and then use a PCR technology to identify the presence of the organism in your blood culture, but not directly in blood.
Thank you, sir. So another interesting question from Dr. Mamta Panda. She wants to know that if the blood culture is negative, that means a culture negative baby, but the clinical situation is like they're not doing good clinically and hypothermic persistently. And so do you start antibiotic in this kind of scenarios, provided other conditions have been excluded?
I'm sorry, we've got a jackhammer going outside here. Let me see if I move to a quieter place.
So if it's a situation where the culture is negative, but the baby is not doing clinically good, so whether to start antibiotics or not.
That's clinical judgment, again, I think you need to have a reasonable hypothesis that there's some focal bacterial infection somewhere. In our population, that's going to be primarily pneumonia. So if you think the baby's got respiratory distress, has chest X-ray infiltrates, signs of an acute inflammatory response, CBC, CRP, whatever, and your culture is negative and you want to continue antibiotics, I'm amenable to that. But I think one of the problems with, I alluded to this in one of the early slides, if we say, well, the blood culture is negative, but the baby's really septic, that stops us from thinking. And we stop asking the question, what's really wrong with this baby? I had a conversation with one of my junior colleagues yesterday evening about a baby who's 4 weeks old, who's continuing to have problems with respiratory distress, and has had recurrent episodes of lactic acidemia. And one of the questions I had for him is mom from South Asia? Is she on a primarily rice diet? He said, oh, she is from South Asia. I'll ask her about her diet. Maybe she's thiamine deficient. Maybe the baby's thiamine deficient. The baby responded at the beginning to support with TPN, got better, but then they transitioned the baby to mom's breast milk, probably also thiamine deficient, if that's the case, and the baby got sick again. So, if we're saying, oh, this baby has culture negative sepsis, and we're just not getting it with the antibiotics that we're using, and we forget to ask the additional questions, we're never going to figure those things out.
Yeah, there are quite a few questions regarding the inflammatory markers like CRP, procalcitonin, elevated CRP, elevated procalcitonin, but you have a culture negative. So what do you do in such babies?
I try to get people not to send those tests. Their predictive value is not very good. If you look at the paper that I published in 1998, which at the time was the largest series of babies who'd had CRPs performed, I think we had about 1,200 kids. Subsequently, there's been one that had about 1,400, came pretty much the same conclusions. One of the things that we looked at was the positive predictive value of elevated C-reactive protein as a function of how high it was. So not surprisingly, the higher the CRP, the more likely the baby was given a diagnosis of sepsis. But if you look at that figure, we have bars for clinically suspected sepsis and for culture-proven sepsis. For culture-proven sepsis, the prevalence of infection was less than 10%, with elevations above about 2 to 3 milligrams per deciliter, and didn't increase much beyond that. For suspected disease, the prevalence was much higher, and it continued to increase as the CRP levels went up. And the problem with that is that the logic is circular, because we relied on the clinician's diagnosis for clinical sepsis. They relied on the CRP to tell us whether there was clinical sepsis. So if it was high, they made the diagnosis. We scored it, and we said that a high CRP was a good predictor of clinical sepsis. It's a good predictor of the doctor thinking there's clinical sepsis, but I have no idea what that means. So I was introduced once at one of these conferences as Dr. CRP on the basis of that paper. And the farther along that I get, the less I think CRP has a role. And I think the same is true for procalcitonin, and so far for all of the other inflammatory markers, IL-6, IL-10, whatever. The problem is that they take too long to become detectably abnormal, and they're very, very nonspecific. So as I've looked at the data, I don't think that CRP adds anything to the diagnostic value of the blood culture. So I would invest the blood, put it in the blood culture bottle, and don't send those diagnostic tests. So I think I'm a bit of a prophet crying in the wilderness in that regard, because most people are going to continue to use these diagnostic tests, but I really think they have very little utility.
Okay, thank you. Dr. Vanita just wants to know how to clinically diagnose or suspect occult focal infections and confidently stop antibiotics if the blood culture is negative. Yeah.
Well, I think you rely on careful examination. I think a chest X-ray can be really helpful. Certainly, if the baby's got signs of respiratory distress, you probably already got a chest X-ray anyway. So the other conditions are a lot more difficult. Osteomyelitis, you're probably going to have to pick up because of abnormal movement of the baby. You'll notice, the baby's not moving a leg because there's osteomyelitis from the area of the hip, things of that sort. So a careful physical exam, maybe a chest X-ray as a screening test. Thinking about meningitis, particularly in the babies who are behaviorally abnormal, not eating well, doing the LP, and then struggling with interpreting the results when you get them back. But it's a really, really difficult task. And that's a place where I think the basic science people who are looking at a more sophisticated systems-based approach to the use of proteomics or metabolomics may be able to help us know which babies are sick because they have some other inflammatory process and which ones are actually activating the innate immune system. Not an easy task.
Thank you. Do you have any advice for low and middle income countries in the management of sepsis, as far as management of sepsis is concerned, or diagnosis as well as management?
Any advice for those
just
of
for
you
the low and middle income countries?
Yeah.
Yeah.
Take everything that those of us that live in high income countries with a grain of salt. We don't live in your environment, and you need to take the kinds of discussions. You'll notice that I didn't give a lot of specific recommendations about what you should do, and I didn't titrate this talk in that way for your benefit. This was the same talk that I gave at the PAS a year and a half ago, and I've given it a couple of times for conferences here in the US. I'm not very prescriptive because, we have more questions than answers. But you can see how I try to grapple with these issues, what the thought process are. So I think you can use the template of the process, but you have to apply the information that you have from your own environments and your own practices. I'm really pleased when I see things coming from low and middle income countries where people are actually doing the epidemiology and doing the kinds of interventions that get to what's really relevant to the populations that are dealing with. It's a different set of problems, and you have to really individualize it to your own settings. I'm very sympathetic. It's hard work.
Thank you. Arjun.
Yeah. So the next question is from Dr. Recién, whether we should treat the sick newborn with antibiotics with rising CRP and negative blood culture.
So what do you do about antibiotics when the CRP is going up and the blood culture is negative? You look for a source of inflammation somewhere. The causes of an elevated CRP, on the paper that we published in 1998, we had a table where there were 36 other diagnoses that were associated with an elevated CRP in our 1,000 babies. And the editors made us take the table out. I think it was a terrible mistake. But the things that we found that are associated with an elevated CRP are things like a stroke. We've had babies that fall ill on day one or are ill from the beginning. We work them up for sepsis, treat them. It turns out not to be. CRP is still going up. Baby's still not behaviorally appropriate. Eventually somebody decides to get an MRI, and sure enough, the baby's got a middle cerebral artery infarct. So if there's an area of tissue necrosis anywhere, the CRP is going to increase. And those kinds of ischemic injuries, unfortunately, thromboembolic disease in babies is typically in the head, but it can be kidney, can be gut. So you have to look for those other focal sources of inflammatory change. The other categories of disease are in that last group that I showed, the inflammatory processes, things like maternal lupus erythematosus. If mom's got autoantibodies and they're affecting the baby's CRP will rise. But that's very nonspecific. Oh, and another diagnosis that we found was really surprising was Rh isoimmunization. There's something about the red blood cell breakdown with isoimmunization that activates the immune system, and the CRP goes up. So, yeah, I wish I had been able to publish that table of 36 other things, but just think of anything that you can imagine that activates neutrophils will bump the CRP. It's a long list.
Thank you, sir. So, Dr. Vanita wants to know, what are the current diagnostics available in clinical practice to diagnose occult focal infections in order to stop antibiotics confidently?
Good question. I think that the key word is probably the last one there. I think as a general phenomenon, we shouldn't be too confident in anything that we do. So if the baby is doing well and the blood culture is negative, that's the easy case, right? Then you can probably be pretty confident that stop the antibiotics, baby's going to be okay. If the baby is still sick and the antibiotics and the culture is negative, then stopping the antibiotics is something you might do with a little bit more trepidation. But in either case, I think you have to continue to follow the baby for a little while. The problem is that when children develop recurrent bacterial infection after partial effective treatment, it doesn't happen in a few hours. I looked at this literature. There's none in neonates, but there's some in older kids. And typically it's 10 days to 2 weeks after the cessation of antibiotics. And we can't keep the kids in the hospital to observe them that long. The reason I looked it up was we used to have a habit. We'd stop the antibiotics and we watch the babies for 3 days, or the children for 3 days, to be sure they didn't get sick again before they went home. So we were watching them during the time when they weren't going to get sick again. And then we send them home and stop watching them when they actually were at risk for that. So I don't know really what the precise answer for that is, except think carefully and don't be too confident. I tell my residents and fellows, what you do is not nearly as important as how carefully you pay attention to the consequences. So, make a decision, go with it, and then realize that maybe it was the wrong one and pay attention and detect that before the patient gets into trouble.
Thank you, sir. So, Dr. Vijay Singde wants to know that in babies with meconium aspiration syndrome, even with history of meconium stent, amniotic fluid, and respiratory distress, usually they have raised CRPs and they get treated for 4 to 5 days with antibiotics. So, should we be ignoring the CRPs and switching the antibiotics at 36 to 48 hours?
Yes, I think so.
If the culture is negative in this kind of scenario.
Yeah, meconium aspiration is a massively inflammatory syndrome. The lungs do not like having meconium down there, and they mount a very nice inflammatory response. So that was one of the things that was on our list of non-bacteriologic causes of elevated CRP. So I would expect that if your cultures are negative, you can stop. Now, one of the corollaries of that is that I'm a big advocate of obtaining tracheal aspirate cultures for babies who have respiratory distress and pulmonary infiltrates at the time of the initial intubation. Now, when you have a chronically instrumented airway, if you have a baby with bronchopulmonary dysplasia, who's been intubated for 6 weeks, and you culture that airway, you're going to find all kinds of horrible organisms down there, all kinds of bad stuff. So that's a complete waste of time. And trying to treat those organisms, so far at least, looks like it's probably a waste of time. The trachea should be sterile, though, initially before you intubate it. So in that situation, I encourage people to send a tracheal aspirate for gram stain and culture. If the gram stain is negative, you can probably cancel the culture. But if the gram stain is positive, then getting the identification can be really useful. And I think that's really helpful in these kids with meconium aspiration, because they're, as you know, they're really sick. They look septic. They've got a systemic inflammatory response that's just raging. They're needing a lot of support. But if their culture is negative and their tracheal aspirate is reassuring, you can safely stop the antibiotics.
Thank you, sir. Dr. Barma, please.
Dr. Mohammed wants to know if the mother has chorioamnionitis and the baby have respiratory distress soon after delivery, is it an indication to start antibiotics and send blood cultures?
Yeah, that baby's sick. Yeah. The answer would be the same. Mom had no signs of any problems at all. Perfectly ordinary, healthy woman, normal pregnancy, labor, delivery, baby comes out, baby acts sick. Yep, that baby needs antibiotics, until you get it sorted. Now, the gray zone there is the baby acts just a little bit sick, is a little tachypnic and requires half a liter a minute of oxygen by nasal cannula. And at an hour of age, we're down to 0.2 of a liter. And the saturations have gone from 92 to 95%. And the baby's improving. That's a baby that you might watch and kind of wait and see how it evolves before you start. But if the baby has respiratory distress that's needing help, the baby that starts out needing a little blow-by oxygen in the delivery room and at 2 hours of age is on CPAP, that baby's ill. Yeah.
Thank you. We are extremely thankful for your patience with our questions, though there are a lot of questions more, but I don't think we have already exceeded 2 hours after starting. I think after 2 more questions, we will stop this discussion.
Right.
Yeah, I think that will do. One question is, if the blood culture is positive on day 5 or 7 due to a fastidious organism, should you take it as a contaminant or a real infection? That is the question.
Yeah, that's probably a contaminant.
Yeah. Okay.
Yeah. The organisms that the cultures that turn positive after 48 hours are very, very rarely true positive cultures. So there's another circumstance that we haven't talked about, which is where the culture is positive, but the baby's entirely well. And this turns out to be an extraordinarily common circumstance. In the Kaiser sepsis calculator, Mike Kunowitz's paper, they had 51 babies with positive blood cultures, 10 of whom were not treated, but they were sending screening blood cultures that came back positive. They then looked at all those babies. Most of them had repeat blood cultures. All the repeat blood cultures were negative. They treated all of them, but none of them got sick in the interval. Well, they didn't treat all of them. In fact, some of them they didn't treat at all ever, and they didn't get sick. So this issue of transient asymptomatic bacteremia with real pathogens, E. coli and GBS, is also a real phenomenon, and it confounds our thinking about these things. It makes it really difficult to sort out what's best. But yeah, late positive cultures, I wouldn't be excited about.
So then with this question, I think we should wind up. Should we do lumbar puncture in all culture positive babies and all late onset neonatal sepsis babies?
Yes, the short answer. For most of my career, my aphorism for the people I supervised was, if you start antibiotics, you do the LP. Simple. We started a lot of antibiotics. We did a lot of LPs. Our trainees got really good at doing LPs. Our yield on our LPs was extraordinarily low, almost zero. But I think if you have a positive culture, if you know that the baby's bacteremic, it's reasonable to look for CSF involvement. Barbara Stoll had a paper in the preterm babies, which is going to be the primary target of your late onset sepsis group, that the prevalence of meningitis in the babies with coagulase negative staph bacteremia was very high. And similarly, in the term baby that goes home and comes back with late onset group B strep, historically, the prevalence of meningitis in that population was more than 60%. In some of the series, it was 90%. So if you've got a baby coming back with late onset sepsis, they need to be screened with an LP.
Thank you. Arjit, I think we will stop.
Yeah, I think we'll stop. Yes.
Yeah.
Over to Dr. Manoj.
Thank you.
Well, thank you for the stimulating conversation. I'm really gratified to know that people on the other side of the world literally are struggling with the same difficult problems that we have here. So let's continue the struggle together.
Thank you, sir. It was such a wonderful session. The audience interest can be reflected in the number of questions that keep coming up. And as we say, all the sweet things need to have an end somewhere. So we will temporarily stop here. But then we would love to have you again on another day, on a virtual as well as in an in-person session in the future, because we really enjoyed your elaborate answers to the questions that we always used to have. Some of these questions have been beautifully answered in your lecture. And I'm sure that anyone who deals with newborns in the intensive care or elsewhere will definitely find some of these areas where we have still not really answered. And then it's such a thought-provoking. I would say we have been running this session since June 2020, 3.5 years. And probably this is one of the best lectures we have had so far. Thanks to you, sir, Professor Benitz. It's such a huge honor for us to have you today. Thank you.
Good.
Sir.
Thank you for your kind words.
Thank you, sir. And
we'll
before we close,
another topic on another day.
Yeah,
sure, sir. We would love to have you again, sir. I would again contact you with suggestions for another talk, sir. Thank you so much.
Thank you, sir.
Thank you, sir.
Thank
Now,
you,
before
sir.
we close, I would also like to thank both the moderators, Dr. Arjit Mahapatra and Dr. Ravindra Verma, two close friends of mine who had done an excellent job navigating through the questions itself was a challenge. Thank you so much, both of you. And finally,
Thank you, sir.
thank you.
Thank you, Dr.
finally, before we close today's session, I would like to express our sincere gratitude and it was such a real honor to have all of you respected attendees for this session. We have been the numbers attendees have been growing as the sessions go, and thanks to legends like Professor Benitz. And now thank you so much for joining us today. Today's session unusually went on from 1 hour to more than 2 hours, and still we can see that most of you are still wanting to session to go on. So we'll have it on another day. I would, before we close, I thank you all, and then I would invite all of you for the next month session, which is going to be a continuation of the neonatal resuscitation. So it's a part 2 of what is new in neonatal resuscitation. Lessons, this time it's about the lessons from chest compression and survive trial by the investigator, the original researcher on that, Professor George M. Schonzer. So again, cordially inviting for the next session. Until we meet again, thank you so much.
Thank you. Thank you.
Thank you. Thank you. Thank you. Bye, Dr. Benitz.
Thank you, sir. Thank you. Thank you so much.
Thank you, sir. Thank you.
Bye. കുഴപ്പമൊന്നും ഇല്ലല്ലോ അല്ലേ